the local chapter chair here in the New York metro region. And I think we have a very exciting program for you tonight, but I wanted to first just give you a few announcements. Next month, on Tuesday, April 17th, we will have our annual Joanne Lecumnick Forum on primary care. The presenter at that forum is going to be Dr. Neil Kalman, who is the co-founder and president of the Institute for Family Health. And I think it's going to be a very, again, interesting session dealing with issues related to primary care. You're all invited, if you are interested, to join us on Sunday, April 29th at the Murphy Center, sponsored by CUNY on, is it 43rd Street? 25 West 43rd Street, where we will be conducting a speakers and lobby training program. So if you're interested in learning how to talk about the issue of universal access to care through a single-payer program, this is a wonderful opportunity to join us. And then, indeed, we hope that many of the people who do participate there, and any others, will join us on Tuesday, May 8th, for an Albany Lobby Day to, in fact, advocate for the New York State single-payer bill that Dick Gottfried has put together. Then on Tuesday, May 15th, we will be having our membership meeting here with board elections, and you'll learn more about that at our meeting in April. So I don't know if there are any questions, concerns that people have at this point. If not, let me introduce Dr. Len Rotberg. Len has been very involved with issues related to the New York State single-payer effort. He is also our treasurer and our local research director. And he's going to moderate and introduce our speakers this evening. So let's put our hands together and welcome Dr. Len.
Thank you very much. We're fortunate tonight to have as our two speakers, speaker and discussant is the way we invited them. Two experienced advocates for consumers in the healthcare field, particularly for low-income consumers of healthcare, users of the healthcare system. Sheldon Toubman is from the New Haven Legal Assistance Corporation. He's been a legal aid lawyer for more than 20 years. He graduated from the University of Connecticut and in engineering, but then from University of Pennsylvania Law School, and since 1988 has been doing legal advocacy for low-income residents of Connecticut, particularly users of the Medicaid program, and has been involved particularly in the struggle over making that system really work for the people it's supposed to work for. And what he's going to do, and what we asked him to do, is to tell us the story of how that system has been transformed through legal and popular advocacy over the last 5 to 6 years, so that it is a very different program than it was before when he got involved. As a discussant, we asked Diane Spicer, who works with the Consumer Health Advocates. This is the opening slide of the slides she's going to use in her discussion. She's the consulting lawyer for Community Health Advocates, which is an organization, a grouping within the Community Service Society of New York, which provides assistance, a hotline system, a helpline system for users, particularly low-income users of the healthcare system in New York State, New York City. Diane is also a lawyer, worked with legal aid well, she's a graduate of NYU and of the Rutgers Law School. For 10 years, she's worked before coming to Community Service Society, I guess just within the last year. She worked for 10 years with Legal Aid Society, particularly on health law and on the legal problems facing low-income residents trying to use the Medicaid program. So Sheldon will talk about what has been done in Connecticut, and then Diane will reflect on the situation in New York State, in which we have a Medicaid managed care program that is expanding in fact this very year. But I look forward to really exciting and really stimulating discussion. So Sheldon will lead off.
Good evening. So I'm from Connecticut. Have any of you driven through Hartford anytime recently? Okay. You should notice that there's these big buildings there, not as big as the buildings here, but there's some big tall buildings there. Notice what they say at the top of them, some of them? United Healthcare and Aetna, and this is a very powerful industry with a lot of money and a lot of lobbyists throughout the country, but particularly in Hartford. So I tell you that because it sort of paints the picture of what we're up against. Len said, we fought this battle for 5 or 6 years. Well, sort of intensely, but we really fought it for like 12, 13 years. So what we had is that in our Medicaid program, Medicaid, of course, is a program for soon to be all, but up until now, generally certain categories of low-income consumers. And those people are generally children and parents of minor children, pregnant women, elderly individuals, and disabled individuals. It varies from state to state. Those are the basic groupings. In Connecticut in 1995, we went to bringing in HMOs to run the system. So up until then, the state paid fee-for-service for all the services that these folks would need. Some people decided that we needed to bring HMOs in to provide health care, and it was sold as being good for quality because there were access issues in Medicaid, largely due to inadequate providers and other things. But it was sold as a quality issue. But really the motivation was to save money. And if you don't believe me, this fact should make it clear. From the get-go, when the HMOs were brought in, they were told they would be paid 95% of what we projected would otherwise cost without them. So by definition, the point was to save money. We started with 11, and over the years, it got whittled down. I'm going to stop sort of at the point where we got to 4, and then we'll go on to the point where we get to 3. It got down to 4, and there were a variety of reasons for that. One of them was like Kaiser was one of them. Kaiser pulled out of the East Coast, so that was one thing. There was one entity that got into some fraudulent activities. The Attorney General went after them, and a variety of things. It was, there was some pressure from us, but to be honest with you, at the time when the shrinkage was going on, it was other factors. Nevertheless, when it got down to 4, we became very aware that there were serious access issues, more serious than there had been before. So basically, people couldn't get in to see providers because there weren't providers. When they got in to see the providers had to request prior authorization for everything, and not everything, but for a lot of things, and could not get prior authorization. They had to get prior authorization repeatedly for the same kinds of services, for the same person, for the same medical condition. And the companies would make it harder and harder to get repeat authorizations. Mental health was a particularly abusive area where the HMOs subcontracted to a specialized behavioral health company, and they got a small portion of the capitated rate, maybe $10 a month, and they would routinely say to kids with horrible, horrible traumatic situations that we've got a policy of 5 sessions. And then, you can come back begging for more. So these things were going on. We also discovered that there wasn't any notices going on. In the Medicaid program, which is a state federal program, it's governed by what's called due process, which you've all heard of. But in the context of welfare benefits, including Medicaid, it means that there has to be written notice explaining why something's denied and the right to appeal and what the denial was based upon and all that. And that wasn't happening. There were no written notices. They just would tell the doctor, no, we're not going to pay for it. So there were a lot of serious issues, and we decided to look at it, and as I said, going back a long time. In 1999, we filed a class action against HealthNet, which was then very big in the East Coast. It's still one of the largest in the country, on the West Coast, and the state, over this lack of due process, lack of written notices when they denied services. And that case went on for a while. There were quite a few depositions. I learned some interesting things about the industry from those depositions. Now, so fast forward to where are we today, and why I was invited to talk to you. Today, as of January 1st, we have no HMOs running our Medicaid program. Remember, for the children and families, they were all put into that system, about 325,000 at the time, and then it grew larger and larger to 400,000. All the families are required to be there. The families are taken out of that, and all of the Medicaid program is now one unitary system. Some would call it a single payer system because there's one payer here. And it is administered primarily through an administrative services organization on a non-risk basis, and that contractor is actually also a non-profit. So basically, the state pays an entity a fee, not for health services, but a fee for administering things, including doing prior authorization where it's deemed to be appropriate. But the critical piece here, in my thinking, is that this entity does not make money one way or another if it says yes or no on a request for prior auth. In a capitated model, the whole point is that you make money by denying care. And in fact, in the case of for-profit, shareholder-owned HMOs, insurance companies, they're legally required to do that because they have a legal obligation to make money for their shareholders. If they don't do that, they're violating their ethical obligations. So they're supposed to keep the cost down. They're supposed to deny claims wherever they can. Okay. So we've moved to a non-risk system that's not just, actually there's other groups in it, not just the Medicaid population, but it's really grown. So it's now in the order of 550,000 people as of January 1st, just passed. Now, in addition to that, there is going to be a heavy emphasis on using patient-centered medical homes, which most of you know what that term is, and it basically means primary care providers are responsible for the patients and paid a little extra to coordinate the care, and possibly incentive payments are included as well for good performance in certain areas. Okay? So we are developing that model at the same time. Okay, so how did we get here? It's Hartford, Insurance Capital, United Healthcare. Oh, I should say, and when we kicked them out, the three we kicked out, one of them turned out to be the ASO, right? They were acting as a capitated nonprofit entity. They're now a non-risk, non-capitated nonprofit entity, and frankly, doing a pretty good job. But the other two were United Health and Aetna, and they got the boot. So how did that happen? I should give credit to our new governor, because frankly, if we had kept the previous governor, I don't think this would have happened. So it had a lot to the election, frankly, had something to do with it. But there was a tremendous amount of groundwork that made that happen. One of the things that was happening during this time is that this program was getting more and more expensive. And one of the things, we were told you 95%, initially the HMOs were going to be paid 95%. That sort of went out the window pretty early on. So remember, the whole point is to save money, but we got rid of that thing of having to save money. This sounds crazy. So we kept doing it. We kept running insurance and provision of care to poor folks when it wasn't really saving money. Why is that? Well, a lot of it has to do with powerful lobbyists. But we did take it on early on that we're going to address the flaws in the system. We're going to hold them accountable, and ultimately, if we figure if enough light was shown on their practices, especially emphasizing the cost aspect, that it's not really saving money, we would be able to move on to a better system. So what did we do? Well, I already told you about that class action. Second thing was the Freedom of Information Act. So in Connecticut, as in every state in the country, there's a Sunshine Law or Freedom of Information Act that says you can get records from the state agencies. You just file a request, anybody, and get all the documents. Yeah, but the state here was contracted with private companies, so how could you get their records? Answer is our act provides that any state contractor that is doing more than $2.5 million a year business and performing a governmental function which is defined in the statute. becomes itself subject to the Freedom of Information Act. So, and this isn't, you could amend your law in New York, by the way, to say this, just, if you want to do that. I encourage you to do that. I'll be happy to send you our language. So, what happened is that, sort of unbeknownst to me, a professor in the Yale School of Public Health was looking at the problem of access to care for specialists for people on Medicaid in the HMOs, and sort of innocently was saying, gee, I wonder if it's about how much they pay the providers. We never can find out how much they pay the providers, but maybe that's it. So she drafts a Freedom of Information Act request and says, you know, I'd like to know, state, how much the HMOs pay their providers. And it listed all these various codes, you know, within cardiology and other specialties, but it listed various kinds of codes, office visit, consult. And before she made the request, I spoke with her and I told her, you know, there's going to be a problem, which is that the state doesn't have that information. They don't want that information. But there is this act, this provision in the act that says if you know, are performing governmental function, then you are subject to the FOIA. I said, I think they are. So put that in there. Put there, and if you don't have it, please get it from the HMOs because they're performing governmental function under the statute. Well, guess what? The recipients of the request disagreed. They didn't think that their state contractors, that they, you know, that they paid $700 million a year to, were performing governmental function. Some of them got $200+ million a year. And even though they took over the role of providing health insurance parallel to what the state itself was doing for the fee-for-service population, remember those other groups, elderly, disabled? The state was doing it directly for those folks, and they contracted the HMOs over here to do it for the larger group of children and families, pregnant women, but somehow that wasn't a governmental function. So we fought this really hard. And one of the things that I learned through this fight is the value of media. That a fight that you have is sometimes not worth it unless you have the media with it. In fact, sometimes the media is more important than the fight. So we emphasize at every step of the way that these are large state contractors taking large quantities of taxpayer money, but they don't want to be held accountable. So when they opposed it, and we ultimately had to go to court, guess what our press releases said? HMOs, huge state contractors don't want to tell the taxpayers what they're doing with the taxpayers' money. Large sums of money. I attached to the outline for those there were hundreds of articles we produced over several years. Our editorials, letters to the editor, newspaper articles, and I attached just 3 of them during a short little window because I wanted to emphasize sort of the way we did this. So the first is an editorial by the Hartford Courant itself saying, make HMOs comply, meaning, oh, they don't want to be held accountable. Well, they should be held accountable. This editorial, the first one, talks about how the governor wants them to be held accountable. Not true. Not true at all. The governor fought us every step of the way. She wanted her contractors to be happy. She doesn't want this business, this craziness of saying they have to be subject to the Freedom of Information Act and their dirty laundry has to be out there. We'll find out that they're not providing health care. No, she fought us all the way. But this editorial follows after series and series of articles of us and legislators saying the governor doesn't want the HMOs to be accountable, doesn't want state contractors to be accountable. And eventually it sort of wore to the point where, okay, she's got to have to take the public position that she believes in accountability. So that's how this editorial starts. Well, the governor wants accountability, so what's the problem? It's these horrible state contractors. It's, the last sentence is, it's unreasonable to expect taxpayers to shell out $740 million to companies that aren't accountable. Amen. That was the basic message. So while this litigation was going on, we won in the Superior Court, and 2 of the HMOs appealed to the appellate court in Connecticut. What we said is, you know what, Governor, forget that court thing. This is a matter of contract. Regardless of what the courts say, you can say you are subject to this requirement, and you have to act like it. And if anybody requests documents, you have to produce them just like you're subject to the Freedom of Information Act. Forget what the courts say about this specific statute. And we really got a lot of allies in saying that, like the Speaker of the House, like the Attorney General, and others agreeing with this to the point where she was really boxed in. But at the same time we were doing press about our litigation, our fight with holding them accountable, we were also calling attention to their bad practices. So the second article, this is an actual article, was about, entitled Managed Care Group Comes Under Fire. This was about HealthNet, the same company we sued, years earlier. It turns out that one of the things that the insurance companies do is, this is shocking. Is this being recorded? Yeah. They lie. They actually lie. So one of the ways they lie, and I suspect, in fact, I think I've read or heard recently some listserv in New York that this is happening in New York. So basically, all the Medicaid drug coverage is extremely broad. Federal law requires that if you're going to cover drugs, which is optional, but every state covers it, you have to cover basically every FDA-approved drug that's out there with the exception of certain narrow categories. I don't know which exceptions New York has taken, but there's very few. Anyway, so drugs are covered. But states are free to, or HMOs are free to have preferred drug lists and formularies whereby drugs not on the list you have to request prior auth. Okay? So basically, when you go to the drugstore, whenever you put a prescription from a pharmacist, he or she types it on their terminal, and it comes back instantaneously. The computer system from their insurance company says whether it's paid for or not. And if it's denied, there's a denial code. And there's 99 denial codes. And there's a denial code that says prior authorization required, which would be accurate in the situation of a drug that's covered but requires prior auth where you didn't get prior auth. There's another code that says not covered. What does not covered mean? It means it's not covered. So HealthNet programmed its computer to, whenever somebody presented a prescription for a drug that requires prior auth and they didn't get prior auth, it's covered. They programmed the computer to say not covered. So the pharmacist would say to the patient, sorry, your drug's not covered. And the person would walk home with the tail between the legs saying, my insurance company won't cover it. Which is true, but extremely misleading in terms of the reason. Okay? So, now, the article, the editorial that I gave you was October 28, and then November 15th, a few days, two weeks later, is an article that one of these same companies that doesn't want to be accountable to the public is basically giving out grossly misleading information, even arguably fraudulent information, in order to avoid paying for things, while they're getting their share of $740 million. Okay? The pressure became so intense that what happened is the governor said to the HMOs, you must agree to this. You don't get any more money unless you agree to this obligation to be bound by the Freedom of Information Act. And again, in New York, as a matter of contract, it's theoretically possible you could require this. Two of them refused. On the day, well, the last one is an editorial that's Medicaid from the New Haven Register saying Medicaid spending is a black hole. If they can't meet this minimum obligation of public trust, their contract should not be extended again. That ran on November 19th. Later that day, much later in the day, the governor issued a 4-page rambling press release saying she was firing these HMOs that won't agree to be bound by the Freedom of Information Act. Okay? We had a period of severe craziness because she's announced she's firing them, and basically it was impossible to continue without them the way the thing was structured, and this part was going forever, so I'll just make the very brief summary of it to say that she decided she was going to recontract out to get new HMOs that will accept the Freedom of Information Act obligation, which ultimately happened, and that's how United Health came in, and that's how Aetna came in. They weren't there before, but they came in response to an RFP which said you will be bound by the Freedom of Information Act. They actually accepted it, which was a little surprising to me, but they did. Okay. What else did we do? We obtained a lot of information. The Freedom of Information Act was part of it, but we also obtained information on their medical loss ratios. You know what medical loss ratios are, which is the amount of money they spend on health care. Well, guess what? Not all of it goes to health care. This is taxpayer money. It's arguably even worse when it's taxpayers' money, which is being skimmed a large portion off the top for administrative costs and profit, than it is in the regular commercial sphere, which is bad. But in this particular case, it's the taxpayers' money So we got those medical loss ratios and we publicized them in one case. So we have Medicaid and also the SCHIP program, which is a program for somewhat higher income but only children, right? A program that's reimbursed by the vets. In the SCHIP program, one of the HMOs had a 62% medical loss ratio. That means 38 cents of every dollar wasn't going to health care. That's kind of newsworthy. And of course, we made sure it was newsworthy. We publicized information about the low provider participation, of course. And one of the things that was extremely helpful here was a secret shopper survey. So in 2006, I think it was, the state, under pressure, not from me or my colleagues, but other advocates, mostly providers, agreed to do a secret shopper survey to get at this issue of, wait a minute, but the HMOs say they've got so many doctors, they've got so many specialists, look at the list, go to the website, they've got so many doctors, how could there be an access problem? Well, maybe they're not really actually participating. So Mercer, which is a major state contractor that a lot of Medicaid agencies contract with for consulting, did a survey. Well, they organized, and I'd say they designed a pretty good one, where they had people calling the doctor's offices in 5 categories. It was primary care, dentists, neurologists, orthopedists, and dermatologists. And they called up and they had fake numbers as if they were Medicaid clients, and they asked to get an appointment. And they found that on average, only a quarter of the time could people get an appointment with the doctor who on the current website of the HMO is supposedly participating in the plan. And and they broke it down, what the reasons given. And a large hunk were, when you add this all up, I don't participate in Medicaid, I do participate in Medicaid but not with that plan, or I do participate in Medicaid with that plan, but only for existing patients, I'm not taking any new patients. When you add up those 3 categories, and then the people, the doctors who were dead, and then the others, you got to a small group of providers who would actually take patients. So we publicized that extensively to say, look, it's a lie when they say that they're providing good quality care. People can't get in to see the providers. Again, at every step of the way, we used the media in order to make sure people knew what was going on, and in order to influence the public, but really to influence policymakers, legislators, everybody who was involved in the system, so they would start saying, maybe there's a better way. And that's what we offer. We've offered a better way. And the better way is something that's been around a very long time, which is having primary care providers coordinate health care. Back in the old days, they used to do it. It turns out that right in the Medicaid Act, there is a specific provision. The Medicaid Act is an extremely complicated, very detailed law, which is going to get more complicated, or has gotten more complicated for 2014. But it has a section called managed care. And it turns out that under federal Medicaid law, there's 2 kinds of managed care. There's the kind we've been talking about, which is where the state contracts with a company for member per month, capitated rate, to provide the health care, and they make money by denying care, the whole thing. There's another kind. It's called primary care case management. And this is not a misnomer. This means the primary care provider manages the case, manages the care, and gets paid a little extra, generally on a per member per month basis, for that care coordination activity, which includes phone, email, speaking with the specialist, various things. It's a model which makes sense, and because this model of managed care does not involve an insurance company taking off that huge amount off the top, it actually can save money. If you're not eating up 15 or 20% for administrative costs and profits, then you have a little bit more money to go around. Coupled with the fact that if you truly are coordinating care, if you really are coordinating care and keeping people out of ERs, and you're preventing conditions from worsening, you really do save money. And this is one of the biggest lies of the industry. The lie of the industry is that we coordinate care. I mean, if all the ads of every insurer always says, we coordinate care, we keep you healthy, we do this, we do that. They don't. And here's why they don't. In the case, I'll limit my comment to the case of the for-profit companies. If you're a for-profit company, what do you care about? You care about your bottom line. Do you care about your bottom line in 3 years? Of Of course not. You care about your bottom line this quarter. If you invest in good preventative care for somebody with diabetes and avoid an amputation or vision problems or whatever in a few years, what's the point of that? That doesn't help your bottom line right now. So there is an advertisement that they do a good job of coordinating care, and therefore they're motivated to keep you healthy because in their bottom line interest. It's really not true. Whereas a primary care provider, who is, after all, even though they may be small doctors, small practices, they may be little entrepreneurs, they're generally mission-driven individuals. They want to keep people healthy. And if you pay them for actually coordinating care, they might actually do it. And you might keep people out of ERs, you might keep people out of hospitals, and you might save a lot of money. Our model for this was Oklahoma, of all places. Right? Oklahoma. Why Oklahoma? In Oklahoma in 2003, they had a, sort of like Connecticut, they had a situation where the HMOs were always demanding more. I left that part of the story out. That in Connecticut, they were always demanding more money. So, they forget the 95%, that was long since by the wayside. They would always ask for more money, they'd always lobby, and the legislature would several years in a row adopt a budget which would give them a certain increase, like a 2% or 2.5% increase, and then lo and behold, at the end of negotiations, they got a 5% increase. How did that happen? And we would call attention to that. Anyway, in Oklahoma, this was happening. The HMOs were demanding more and more money. In Oklahoma, they had some problems with coverage by the HMOs in a couple of counties. So they created this little program called Primary Care Case Management. It doesn't involve HMOs, just for those small parts of the state. And they provide health care very well to families in those Medicaid enrollees in those parts. These HMOs said, we want more money. And there was a fight with the legislature, and the legislature was willing to offer so much money, and one or two of the HMOs, I can't remember exactly how in depth, but basically said, no, we won't do it for that amount of money. Thinking that, okay, well then we'll get more money. Play hardball, we'll get more money. Because what are they going to do? What are they going to do? They need us, right? Well, the state said, actually, we don't need you. We have a model here. And in 4 months, they went cold turkey from, they made the announcement, this was like October, November, and then by January, they started the conversion. By April 2004, a few months later, they had completely gotten rid of the HMOs and had gone to a statewide system of primary care case management, where the state pays all the claims, where primary care providers are paid a little extra for coordinating care, and that's still the system they have today. So that's been in operation 9 years. So what we did was hardly radical. The thing that was difficult was moving away from that system where the insurance industry had so much power. And I suppose the last thing we did is we educated the gubernatorial candidates coming in about what the problems were, how this is getting so expensive, and yet they're doing a lousy job, and they won't be held accountable. And there's an alternative. In fact, we did get passed by the legislature a small program of primary care case management. And what we said to the gubernatorial candidates is, no matter who of you wins, this is something you want to do when you come into office. When he came into office, Governor Malloy, it was his first major announcement. He had brought his budget director and the Commissioner of Social Services in to announce that come January 1st, 2012, as passed, they were going to replace the insurance industry entirely with one non-risk administrative service organization, and they proceeded to do an RFP for that, and they chose, I'm pleased to say, because I think they did the best job within the capitated system, they chose the one HMO that's really a nonprofit, which had the best medical loss ratio, which from best to me means highest, and they took over the contract and are running it for the whole state. I mean, the state has extensive involvement in it because they set all the policy, but the ASO doesn't allow it. And that's why the governor, ultimately did what he did. I really should be finishing up. So I just, in the outline on the second page, I gave some of the things you could do. I mean, I mentioned the idea that's on this list, which is amend your Freedom of Information Act to apply to governmental contractors, right? Or even be more specific, governmental contractors, including Medicaid managed care organizations. Take care of it. I don't know if that's going to work or not. But all the things that we did, you can do in terms of data collection. In this outline, I mentioned that you can collect data on how much your child welfare agency is spending on health care for children. Does it work that way, where kids in the child welfare agency, are supposed to go to the HMOs for health care? Foster kids, yeah.
Not yet, but it will.
Okay, so basically what we found is that these HMOs that are given total responsibility and told you must provide all health care, including behavioral health services for these kids, and you're getting a fully capitated rate to do that, the state was spending millions of dollars for health care for those same kids through direct payments, which made no sense because the HMOs were responsible for that. So the point is that we actually did not succeed in getting the dollars, but we tried to get that information because it sort of tells you, it sort of deals with this cost effectiveness thing. They say they're saving money. Are they really? What about the other costs? What about the other state agencies that have to pay for all the gaps that are created by an HMO that refuses to pay for behavioral health services that are routinely required by these groups of kids? The other thing I would emphasize is that if you were going to move towards primary care case management, you have to talk about it as managed care. Because today, everybody's supposed to be managed care, right? It's a hot thing. So you say, this is managed care. It's defined by federal law as managed care. But it's a far better model. And then throughout, you have to talk about how it can save money. Because they talk about how it saves money. That's their whole shtick, is that we're going to save money. And when you start digging into it, you find, as in Oklahoma, as in other states, Illinois, that have done it, primary care case management, they find that actually, when you factor in all the administrative costs and profits that do have to come off the top, it could well be cheaper to not have them at all. And lastly, another approach is if there's resistance, then as we did when we got primary care case management initially in Connecticut, you argue it as a competitive thing. Everybody believes in competition and free enterprise. So therefore, if the HMOs are doing such a great job, they shouldn't mind a little bit of competition from another system, a well-tried and true system, which, by the way, is in effect to some degree in over half the states in the country, to some degree. Why not a little bit of competition? It certainly couldn't hurt anything. So that's it for the outline. There's one thing I did want to wrap up with, and that is what we're doing right now, and that is, besides developing the patient-centered medical home model, see how it's going to work and how it's going to, is it really going to deliver care, and what's the payment method going to look like, and what are we going to measure, and how are we going to incentivize providers for doing a good job? All it has to be really worked out. We are also dealing with the implementation of federal health care reform and one of the specific options under it. Okay, one of the options that probably very few people will have heard of is something called the Basic Health Program. Ever heard of the Basic Health Program? Okay, so here's the thing about this Affordable Health Care Act that you heard about. That's going to be heard in that court down in Washington. So that it's kind of going to be expensive for low-income people. Now, there's a Medicaid expansion up to 133% of federal poverty level. So we get rid of those, elderly, disabled, and blah, blah, blah. It's basically non-elderly below 133, not in Medicare. Everybody's going to be in that program, up to 133, which means a lot of expansions in a lot of states. Okay, but if you're at 134, there's a disregard, 5% disregard. But I mean, if you don't have much money at 135 or even 150% of poverty, it's going to be a real challenge. And there are some smart people in Congress who recognize that. And so the law also gives every state the option of adopting the basic health program as an alternative. And the way it works is that you all know these, I'm not going to go through it if you don't know, but the way the exchanges work is you go over there, if you're uninsured, to buy your insurance, and up to 400% of poverty, there are subsidies through the federal tax system to help you buy it. And they taper off as you go higher up. Well, for people between 133 and 200% of poverty, the states were all given the option of taking the money that would otherwise go to the exchange through those tax subsidies. Actually, the state would get 95%, not 100%. 95% of what it otherwise would pay to the exchange goes to the state to instead run a basic health program. which has to provide at least what's available in the health insurance exchange. Now, here's what's nice about that in the case of Connecticut or Oklahoma. Because we have created a completely non-risk unitary system for everybody in Medicaid, which is now going to be 133 in 2014, if we run a basic health program and got that federal money different source, couldn't we put those, in Connecticut it's estimated to be about 100,000 people, couldn't we take those folks and put them in the same system? And that way, when parents fluctuate above and below 133, they'd be in the same system. If you had the exact same provider network, they wouldn't have noticed, and their kids and the parents would be in the same system because kids are going to be protected under Medicaid beyond 133. Kids and parents, same program, same plan. You could have the same cost-sharing protections that you have in Medicaid. That's exactly what we're arguing for in Medicaid, is that we have one seamless, unitary, single-payer system for all Connecticut residents under 65 between 0 and 200% of poverty. For some reason, the insurance industry in Connecticut have come out against this proposal. Okay.